Common skin diseases of the vulva. Red down there.
None of the authors of this video have any financial disclosures. The ACOG Practice Bulletin regarding diagnosis and management of vulvar skin conditions from May 2008 lacks photographs or illustrations to help learners understand vulvar dermatoses. The purpose of this video presentation is to review normal vulvar anatomy as well as review the diagnosis and management of benign vulvar skin conditions. Lastly, we will consider the comorbidities associated with each dermatoses. Here is an example of vulvar papillae, a normal variant of vulvar anatomy. They can be described as discrete, small papules that are pink or flesh-colored, located around the edge of the vestibule. Another example of normal variants in vulvar presentation are foxfordite spots. These present as small papules that cover the labia minora, spare the vestibule, and shrink in menopause. Foxfordite spots are best seen when gently stretching the labia.
Vulvar lentigo are also ill-defined and present as homogeneous brown macules. Lichen simplex chronicus is the result of the reaction of the epidermis to repetitive mechanical trauma, e.g., scratching and/or rubbing. The skin becomes lichenified, thickened and rough, with well-defined papules and plaques.
In long-standing disease, the skin appears thickened and leathery, and the areas of hyper and hypopigmentation are seen. Erosions and ulcers can also develop, most commonly from chronic scratching.
Lichen simplex chronicus is a clinical diagnosis. You can biopsy it, but it is often unnecessary.
An important component of the lichen simplex chronicus disease is patient education. I actually draw a diagram of the itch-scratch cycle and manage their expectations. Steroids are another form of therapy for lichen simplex chronicus. A fingertip unit is from the distal portion of the index finger to the distal interphalangeal joint. One fingertip unit is approximately 0.5 grams. The skin over the labia majora is steroid resistant, so we usually utilize high-potency steroids such as fluocinolone. In fact, it is the potent steroid that is going to stop the itch-scratch cycle by decreasing inflammation. Lichen sclerosus is one of the most common papulosquamous diseases that a gynecologist will see. On examination,
white atrophic mucosa appears similar to cigarette paper on the medial labia majora and labia minora.
Characterizes lichen sclerosus. Typical lesions of lichen sclerosus are porcelain white papules and plaques, often with areas of ecchymosis or purpura. Fissures occur as with a loss of architecture. Here there are also absent labia minora.
Lichen sclerosus
Can lead to fusion of the tissues over the urethral meatus and a dangerous degree of urinary retention. It is important to note that lichen sclerosus does not occur in the vagina, so it distinguishes lichen sclerosus from other diseases. The vulvar and perianal skin may be erythematous in a figure of 8 or hourglass shape around the clitoral hood and then fan out around the anus. Patients presenting with lichen sclerosus most commonly report pruritus, followed by irritation, burning, dyspareunia, and tearing. Because other vulvar diseases can mimic lichen sclerosus, a biopsy is necessary to confirm the diagnosis, except in a prepubertal child. Clobetasol or fluocinolone are potent steroids used to treat lichen sclerosus. This is an example of vulvar lichen planus.
Lichen planus can present in several forms. The most common form affecting the vulva and vagina is erosive mucosal lichen planus.
Symptoms include itching and burning, which are similar to lichen sclerosus.
The difference is in what comes first, itching or burning. For lichen planus, burning comes first. For lichen sclerosus, itching comes first.
Remember, this is a disease of the lymphocytes attacking and eating away at the epidermis. This inflammation manifests as synechiae, scarring, or vaginal stenosis. Lichen planus affects approximately 1% of the population and 100% of patients on oral board examinations. The classic presentation of lichen planus on mucous membranes, including buccal mucosa, is that of white, reticulate, lacy, and fern-like striae, also known as Wickham striae. Over time, these eroded surfaces may adhere, resulting in synechiae and eventually complete obliteration of the vaginal space. When sampling ulcerative areas, 2 biopsies are preferred. When sampling eroded areas, a biopsy of the thickest region is recommended directly and at the edge. We recommend a soak and seal approach for the lichen planus. Soak with sitz-baths and seal with high-dose topical steroids. Although symptomatic improvement is possible, patients should be advised that complete control is not the norm. Rather, vulvovaginal lichen planus is a frustrating, chronic, and recurring disease that requires long-term maintenance. Vulvar skin conditions are common, and it is important to accurately diagnose each condition for proper treatment and prevention.